Good morning, everyone. Welcoming you all to our Sunday CME. Today we have a very good speaker, our specialist anesthetist, Dr. ManjuNath, who is speaking on the topic anesthetic considerations in pediatric patients. Going back to doctor's academic background, doctor did the MBBS from Vijayanagara Institute of Medical Sciences, Karnataka, and DNB from Jawaharlal Nehru Medical College, Belgaum, Karnataka. Doctor has a vast experience in working at various prestigious medical institutes like Hyderabad Kidney Center, Asian Institute of Gastroenterology, to name a few. And Doctor has been working with Ahalia since 2013 December. Welcome, Doctor, for presenting the CME. Thank you.
Yeah, thank you, madam, for your kind introduction. Good morning, everybody. Today, my topic is like anesthetic considerations in pediatric patients. So, why this pediatric topic has been chosen is like this pediatric patients, they are unique in nature because like all pediatric patients doesn't fit the size, means like one size doesn't fit all the patients. So each and every pediatric patients, they are unique because like if something goes wrong in this pediatric population, the resuscitation is very difficult. Means like suppose there might be like cardiorespiratory arrest in this particular pediatric patient groups, then it is very difficult to resuscitate in this particular patients. And especially if you see in obstetrics also, the resuscitation in this obstetric as well as pediatric population is very difficult. So like why it is difficult and what are the challenges that the anesthesiologist has been facing, and like what are the implications, like what we have to consider as an anesthesiologist in pediatric patients. In my following presentation, we'll be discussing about this particular topic. So my main objective is to discuss the various anatomical and physiological changes in this particular patients, then pharmacological differences between the pediatric as well as adult patients. Then I'll be discussing with the after anesthesia how to monitor this particular like preoperative assessment, preoperative preparation, intraoperatively how to monitor, and postoperatively what are the possible complications and what are the various options of pain operative postoperative pain relief. So those kind of things I'll be discussing in my particular topic. So some of the definitions, like prematurity has been described as less than 37 weeks of gestational age. Neonate has been described as 0 to 28 days after birth. Infants is described as 1 month to 1 year. Toddlers 1 to 3 years. Children 3 to 7 years. Older children 7 to 12 years, and adolescents as 13 to 18 years. So, as an anesthesiologist, like first we will go from head to toe. There are various changes which has a various implications for the anesthesiologist particular. Like from head to toe, if you see the airway, then if you go for cardiovascular system, respiratory system, gastrointestinal system, musculoskeletal system, if you go for hematological system, so there are various systems which has been like there are various changes when compared to adult. So it is unique. We have to differentiate the changes that are present between the child as well as the adult. So whatever anesthesia we give to the adult, it is different from the child. It's not similar. Everything, the scenario, it keeps on changing. It depends upon from child to child. Each child is a different one. So like we can't say that like one particular child, this is the anesthesia plan. We can't do like that, because like each individual to individual it varies from child to child. So just like we'll consider like first coming to the airway changes. So the airway changes, if you see, in case of child, the child's tongue, it is larger in proportion to mouth. So in case of an adult, if you see, it's like curved. The tongue is curved, whereas if you see in case of child, it's like straight. And because of this larger tongue, the most common cause of airway obstruction in children is because of tongue fall. So proper positioning of the child, proper positioning of the airway itself, it resolves most of the problems which has been faced by the anesthesiologist. So this is coming to the airway. If you see the larynx, that which is usually present at the level of against cervical vertebra. Usually in case of adults it is C5 to C6, Whereas in adults and children, it is like C3 to C4, or it may be anterior also. So it is more anterior and more superior in child. So, and if you see the epiglottis is floppier and U-shaped in child, and it is very stubby. It's not like easily mobile actually. So whereas in case of adults, it's like it's very easy to visualize. Whereas in a child, it is very difficult. So if you see, because of this large uh, tongue as well as the larynx, which is more superior, there is technical difficulties during laryngoscopy, visualization of the larynx. So we have to keep in this particular consideration. So if you see, larynx is located at the level of C3 to C4 as compared to adults C5 to C6. So most probably we have to use straight plates. As I told you, straight plates for intubation. So this the straight plates, if you use the laryngoscopy, it is very easier when compared to adults. Adults, we have to use the curved plates. We can't use the straight plates in case of adult. So infant larynx is it actually funnel shape, and the narrowest portion which is occurring at the cricoid cartilage. So in infants or in children, if you are using an endotracheal tube, it easily passes through the vocal cords, and during extubation it will become difficult, because if you use cuffed endotracheal tubes, the cuff, it presses onto the subglottic area of the cricoid cartilage. So for this reason we have to use uncuffed endotracheal tubes, preferably like lesser than 6 years of age. We have to use uncuffed tubes rather than cuffed endotracheal tubes. So if you see during intubation, so what are the considerations we have to keep in mind actually? So if you see the right and left positions, if you see, these are the normal positions like for intubation. So there is in this normal position, in the supine position, if this is a neutral supine position what we are seeing. So in this case, there is neck flexion over here. So we can see here clearly the neck flexion is present. So in this case, intubation, it might be technically difficult, maybe it will become easy also, depending upon the situation. So for to contract this neck flexion, the towel is being placed between the shoulder blades so that to contract this neck flexion. But if you keep as in adults, like what we do, the like morning in the sniffing air position, if you keep the head towel under the occiput, so there is more of neck flexion, so it is very difficult to open the mouth as well as difficult to visualize the larynx. So this is the normal position like in case of an adults what we use. So if you see, there is like three axes: oral axis, the pharyngeal axis and the laryngeal axis. So there is alignment. If you for intubation, we have to keep the head towel under the occiput, so that this laryngeal axis and the pharyngeal axis, they will be in the same plane and for visualization of the larynx. So this is very important in case of an adult. So if you want to keep the same morning the sniffing air position in case of pediatrics, so same headrest we have to keep under the occiput, but we have to keep this shoulder roll. This shoulder roll is very important to have the neck extension. So coming to the cardiovascular system. So as soon as the baby is born, the pulmonary vascular resistance falls at birth in response to rise in PaO2 as well as pH and fall in PCO2. So after this, there is subsequent closure of the foramen ovale and the ductus arteriosus, which usually it gets reversed with hypoxia and acidosis, leading to pulmonary hypertension and right to left shunt. So it's called as transitional circulation. So at any point of time, if there is patent foramen ovale and ductus arteriosus, and if there is induction of hypoxia, acidosis in cases of pediatric patients, those who are having persistent foramen ovale, it causes pulmonary hypertension and causes right to left shunt. So this we have to keep in mind in case of preterm neonates, especially preterm infants. The changes, it will be still persistent. So these things we have to keep in mind. If you see the neonates, they have very smaller ventricles with reduced contractile mass and poor ventricular compliance. So what it means is like they have very fragile ventricles, the ventricular mass, left ventricular mass, the muscle tissue, it is very less in quantity. So if we give the fluids, usually what the intravenous fluids what we are giving for maintenance or induction of anesthesia, we have to limit the intravenous fluids depending upon the weight of the child. So we should not keep on giving the fluids because of decreased reduced ventricular contractile mass as well as poor ventricular compliance. There is chance of fluid overload and chance of pulmonary edema is there. So we have to be cautious regarding that. Cardiac output is higher in case of higher than adults, and it is also rate dependent. So that means if you see cardiac output, if you the normal formula is like stroke volume into heart rate. So as the heart rate increases, cardiac output also increases. This holds good in cases of adults also. But the specialty in cases of pediatric patients is there is fixed stroke volume. So the cardiac output is usually it will become heart rate dependent then. If any bradycardia, any episodes of bradycardia is there, so we should tachycardia if it is there, like about 200 heart rate, it is well tolerated, but above 200 it cannot be tolerated. At the same time, bradycardia also we should be like we should not induce bradycardia. For example, like whenever there is like tonsillectomy surgeries, adenotonsillectomy surgeries or squint surgeries, there is stimulation of vagal nerve which induces bradycardia. So first thing is like we have to stop the stimulus. That like we have to stop the surgery, give 100% oxygen rather than giving atropine. Because if you are giving atropine, then what happens is the heart rate increases more than 200, so it cannot be tolerated. So in this case, we have to first stop the stimulus. That is like if you are doing the surgery of squint surgery, so you have to stop the surgery, give 100% oxygen. So it should be treated. The hypoxia is the one which is causing bradycardia rather than the other causes. So infants or neonates who's having less than heart rate 60, they require external cardiac compression. So according to Paul's guidelines, these are the various normal heart rate, blood pressure and respiratory rate according to this particular age groups. So about 12 years we have like 60 to 100 beats per minute, systolic blood pressure 110 to 135 and diastolic 65 to 85. If you see neonates, premature or like 110 to 170. So above 170 or like the infants, they will not tolerate this particular heart rate. So if you go to the respiratory system, at birth, each terminal bronchiole, it opens into single alveolus instead of fully developing alveolar clustering. Alveolar growth, it continues to multiply until the age of 6 to 8 years. The intercostal muscles, they are very poorly developed with lower proportion of type 1 muscle fibers and fatigue more easily. So what it means is like if the patient is being anesthetized and you are ventilating the patient with the Jackson-Rees circuit. So if the patient is being left for spontaneous ventilation without paralyzing, then because of poorly developed intercostal muscles and the paucity of type 1 muscle fibers present in the diaphragm, they undergo more fatigue. The alveolar ventilation, it becomes more, so they become very fatigued and ultimately it can lead to respiratory failure. So if the prolonged surgeries, like if you go for laparotomies or like if you are planning for major surgeries, so better we have to go for controlled ventilation rather than spontaneous ventilation. So in those cases also, if you are using like face mask ventilation for short surgical procedures, so there are chances of abdominal distension, which again which caused due to splinting of diaphragm, and again it leads to respiratory failure. So with these changes, there is minor decrease in functional residual capacity. Because of this decrease, there might be increase of pulmonary shunt and leads to lung collapse. So what we have to do is we have to give continuous positive airway pressure, which improves the oxygen and in turn it reduces the work of breathing. If you see the nasal neonates, they are obligate nasal breathers. Most of the child, they breathe through nose only. So and because of seasonal variation, most of the child, they have nasal congestion, and always there might be blockage of nasal airways. So Because of this one, there might be like 50% of the total airway resistance is contributed by the nasal airway itself. So in these cases, apnea can be the most common post-operative problem in preterm neonates is apnea. So if this apnea, if it exceeds more than 15 seconds or more, there might be chances of cyanosis or bradycardia in these particular patients. So if you go for gastrointestinal changes, the liver is immature. The enzyme systems, in case of an adults, like where there is phase 1 reactions and phase 2 reactions, phase 1 it contributes like oxidation, reduction, hydrolysis, and phase 2 there is a conjugation of the drugs. So this system, enzyme system, that is phase 1 and phase 2, they usually get matured by 12 weeks of age, and some of the drugs they are metabolized by different pathways as compared to adults. The most probable drugs what we are using is barbiturates as well as opioids. In case of neonates, the action it will be prolonged as well as enhanced. So because of poorly developed the glucuronide transferase system, because of that phase 2 conjugation reaction, it is poorly developed. So there is chances of bilirubin metabolism is affected. In that cases, the unconjugated bilirubin it increases gradually and leads to there will be neonatal jaundice as well as cardiac arrest and usually this if the jaundice is too severe, the unconjugated bilirubin it easily crosses the blood-brain barrier. Some of the drugs like sulfonamides or diazepium or vitamin K, they displace bilirubin from the plasma proteins and exacerbate the jaundice. More so, if you see the hepatocytes are also poorly developed. The reserves, that means the glycogen storage, is less in case of neonates. So whenever there is the premature baby or the stressed neonate, they are most vulnerable to hypoglycemia. And vitamin K dependent clotting factors, they are also low at term. So during the first week of life, if you are planning for surgery in these particular cases, like major surgeries like laparotomies, so routine administration of vitamin K 1 milligram per kg IV have to be given to prevent the hemorrhagic disease of the newborn. And more so, if you see, there is reduced lower esophageal sphincter tone, and because of this, there is chances of aspiration pneumonia in these particular patients. As such, if you see, the lower esophageal sphincter usually fully develops in case of adults also. Even then, we advise them for fasting. But if you see, in case of children, fasting is mandatory. Apart from that one, there is no guarantee that even after fasting, there is no chance of aspiration pneumonia. So because of the back mask ventilation, face mask ventilation, there is increased tendency to distend the stomach during back mask ventilation, and at times, sometimes what happens is like because of there is a distension of stomach, the lungs cannot be ventilated. So those things we have to keep in mind. If you go for kidneys like nephron formation is usually complete at term, but renal function is immature, and there is reduced renal blood flow because of high renal vascular resistance. The GFR it reaches the adult values by 2 years, and the tubular function by 6 to 8 months of age. Neonates cannot excrete a large solvent or sodium load. So because of this reason, we should not use the sodium containing intravenous fluids. If you see the normal intravenous fluids like ringer lactate, dextrose normal saline or normal saline, what we are using in case of an adult, the concentration of the electrolytes is very high when compared to like what we are giving in case of pediatric patients. So we should not use the same concentration what we are using for the adult patients. So there are like solutions like isolate P or isolate M, where the sodium concentration, where the electrolyte concentrations is low as compared to normal intravenous fluids. So in these cases, because of the same reason, we have to use reduced drug doses. The dosages it should be reduced, and in the frequency intervals should be prolonged. For example, like if you are giving like a muscle relaxant only for planning for half an hour, and you are repeating for every half an hour in case of an adult, in this particular patients, maybe it might be extending from 45 minutes to 1 hour. After 1 hour, we have to repeat the muscle relaxant. So that is what like it means like prolonged frequency intervals may apply. So if you see the blood volume, so why this particular thing it is important for anesthesiologists. So because like if you are there where there is chance of increased bleeding, say if you are doing like any liver laceration, whenever there is liver laceration or laparotomy, in those cases where there are chances of blood loss is more. So we have to know like what usually the adult, if you see the circulating blood volume is 60 to 65 ml per kg, where if as you can see in case of child, infant and neonate, the circulating blood volume is increasing. So child is 80 ml per kg, infant we have to accordingly we have to calculate per kg body weight, and then we have to calculate the blood volume. If you see at birth, the predominant hemoglobin type, it is like fetal hemoglobin, that is HbF. Most of them, the hemoglobin is 80 to 90% is HbF, and the rest is HbA, the adult hemoglobin. So by 4 months, it will be this concentration is fallen to 20 to 15%, and it is being replaced by adult hemoglobin. If you see the fetal hemoglobin, they have higher oxygenity, higher oxygen affinity, and because of this one, the chances of hypoxemia in case of children is more when compared to adults. So any hemoglobin below 10 gram per deciliter, it should be considered as abnormal, and the child should be investigated thoroughly. If you go for brain, the neurons they are complete at term, but the total number of brain cells is reduced. Then the dendritic proliferation, myelination, synaptic connections, they were well developed in third trimester and first 2 years of life. As I told you, like because of poorly developed blood-brain barrier, it is more permeable to most of the drugs, like especially barbiturates, opioids, antibiotics, and bilirubin, which easily crosses the blood-brain barrier. Especially the barbiturates and opiates, what we are using during anesthesia, they cause respiratory depression, and there might be chance of respiratory arrest also. So these things we have to keep in mind. If you go for auto-regulation of the cerebral circulation, it is present since birth. From birth onwards, the auto-regulation is intact. And since the brain contains higher proportion of fat, which allows volatile agents to reach the higher concentrations more rapidly. So this thing we'll be discussing under the like pharmacokinetics and pharmacodynamics, what changes we'll be having, that we will be discussing in the later slides. And like most of the child, they usually cry. No matter like for what reason, if you keep them quiet, calm, whatever it might be, because of anxiety, because of any reasons, they cry. So then during post-operative period or like pre-operative period, the pain, the cry is common. So we have to differentiate like whether it is because of pain the child is crying, or like due to some other reasons. So these things we have to differentiate. So whatever it might be, all neonates, however immature, they feel pain. So the reason being is like there is increased transmitters that are present during the pain mediating nociception that is present. It is usually they are hypersensitive, and more so because of in neonates, in premature neonates, there is circulating still endorphins as well as progesterone that are present. The progesterone itself is sedating in nature, so they have more concentration, so they feel very sleepy. So the dosage requirement of volatile agents also it varies according to the age. So if you see the pharmacological differences as compared to adults, so what specialty is there as compared to children as well as adults? So the changes usually depends upon the body composition, protein binding, body temperature, distribution of the cardiac output, maturation of blood-brain barrier, liver and kidneys. So if you see, there are various compartments in the body, like fat compartment, muscle compartment, water compartment. So these also it contributes with the drugs what we are going to use. So the total body water content, it is significantly higher in premature than term infants. So fat and muscle content, it increases with age. So because of these alterations, we had to see that like most of the drugs what we are using, so we have to accordingly we have to increase or decrease the dosage. So for example, if you see the drug which is water soluble and has larger volume of distribution, they usually require larger initial dose to achieve the desired blood level. So that means what we are using this succinylcholine, 1 to 2 milligram per kg is the dose what we are going to use in case of an adults as well as children also. So in this case, we have to use more than 2 milligram per kg because it is water soluble drug and it has larger volume of distribution. So the initial dose what we are going to give as an induction dose is higher when compared to as I told you, the frequency of the intervals, the subsequent dosage should be reduced. The frequency should be reduced. Same thing, the thiopenton sodium, what you are using as an induction, intravenous induction agent. So because neonates they have less fat and the drug it depends on the redistribution into fat for its termination of its action. They have longer clinical effect. So thiopenton it causes more of respiratory depression. So the chances of respiratory depression and the clinical effect is more. The duration is more as compared to the other drugs. So in muscle compartment, if you see the drug what we are using, fentanyl, the opioids, the redistribution takes place into muscle. So there is still again there might be chances of prolonged effect. If you go for inhalational anesthesia, so the term called as minimum alveolar concentration. So minimal alveolar concentration, the terminology itself is there like minimum alveolar concentration. So the concentration in the alveoli to prevent 50% of the movement in response to standardized surgical stimulus. So this is the definition of minimum alveolar concentration. This minimum alveolar concentration, it is equivalent to the concentration that is present in the alveoli. It will be same will be there in case of brain also. So this MAC, it usually according to the age of the baby, it goes on increasing as well as decreasing. So in case of geriatrics, the MAC is decreased. In case of neonates, MAC is increased. So the full-term infants, they require lower concentration of volatile anesthetics than do infants like 1 to 6 months of age. So we have to decrease the anesthetic requirements in neonates may be related to immaturity of central nervous system and because of increased circulating concentration of progesterone and beta endorphins. As I told you, the progesterone as well as beta endorphins, they itself are sedating in nature. So the concentration what we are giving the intravenous or inhalational, we have to reduce the dosage because of this particular reason. So as I told you, MAC steadily increases until 2 to 3 months of age, but after 3 months, the MAC steadily declines with aging. So we have to consider that one that like in neonates, the MAC is increased, whereas in case of adults or like puberty, we have to decrease the dosage. So what like makes the specialty, like what the uptake and the elimination of the inhaled anesthetics in pediatric patients is like increased? Why it is more rapid? Why when compared to adults? What is the reason behind is like the pediatric patients as usual they have increased respiratory rates. Because of increased respiratory rate, the minute ventilation also is increased and they have the higher cardiac heart rate, which is like as I told you, the fixed stroke volume, fixed cardiac output state. So the heart rate also is increased. Because of that one, the cardiac index and there is a more distribution of cardiac output to vessel rich organs. So because of this reason, the uptake and elimination, it is like quick, rapid onset and rapid recovery in case of rapid recovery of inhaled anesthetics. So thermoregulation, if you see most of the children in pediatric patients, the head is larger when compared to the rest of the body. The head is the major part where there is major heat loss from the head. So we have to see that the heat loss should not be there. So whenever there is more heat loss, there is impact on the recovery of the patient from anesthesia. So in pediatric patients, there is a term called as non-shivering thermogenesis. If you see in case of an adult, there is shivering thermogenesis. Whenever we are exposed to cold, adults will shiver. So why in case of pediatric patients there is a mechanism called as non-shivering thermogenesis. So the difference is in non-shivering thermogenesis there is metabolism of brown fat. This brown fat is usually found in the scapula, shoulders, legs, and major thoracic vessels. So, in this brown fat, why it is brown is because there is lot of mitochondria in it. Because as you know that like mitochondria is called as a storage powerhouse of the cell. So there are more ATP release. So because of more ATP release, there is more increase, more oxygen consumption. So this may it becomes worse if there is if it is pre-existing hypoxia. So this brown fat it is deficient in case of premature infants. So usually, as I told you, the heat loss is because of conduction, convection, and radiation. So neutral thermal environment should be there in operation theater by using this infant radium warmer or by using this humidified. This is called as heat moisture exchanger. So because of this one, the humidity that is present in the airways it will be reduced. The heat loss will be reduced. So we have to use this particular whenever the infant or the neonate is very small, it cannot accommodate in the normal operating table. So in some of the surgeries we have to perform surgeries in the radiant in the same box as well, so that the temperature is being maintained. In other normal operating theater conditions like operating table, what we have in the normal as in adults, that temperature regulation is not possible. So most of the pediatric or neonate cases, we perform the surgeries in the on the warmer, on the infant radiator warmer itself. So what are the measures to conserve heat loss? So we have to increase the temperature of the operation theater before the patient is being taken. Doors always should be closed, and as I told you, we have to, because of the head is large, so we have to cover with some ganji or even polythene so that like the heat loss is being minimized. And we have to use always warm anesthetic gases. This heat moisture exchanger, this is the HME filter what I am going to tell you, like which reduces the heat loss. We have to use all whatever the fluids what we are using, it should be warm. And if at all the laparotomy is being performed, so the cleaning fluid should be kept warm. And wherever the major surgery has been planned, especially in case of neonatal surgery, temperature measurement is mandatory. So routine preoperative assessment, like whenever the child is comes for the anesthesiologist, like this particular surgery, for example, circumcision or like adenotonsillectomy or like squint surgery, posted for surgery. So anesthesia consultation is mandatory. So by this, like what we are going to achieve is we are going to establish a rapport with the parents and children. Usually, parents they usually accompany the children. So parents will be having very they are very anxious, they are very worried about the children, like if we give anesthesia, if they doesn't wake up, then what is the plan A, plan B? So those things, the parents will be worried. So the communication should be very simple, informative, and you have to be truthful to the patient. If the child is older, so we have to speak with the child. We have to reduce the anxiety of the child by showing the photographs or any video if it is present. So we have to show them. So coming to the like assessment, we have to, as usual, we have to go for weight assessment. Then any cardiovascular abnormalities, usually the vectoral abnormalities, that is V8, CTERL, the mnemonic what is present, that is like vertebral anomalies, anorectal anomalies, C for cardiovascular abnormalities, T for tracheostomy fistula, R for renal anomalies, or L for limb anomalies, if at all that is present in case of premature neonates. We have to assess the cardiovascular respiratory system, and we have to go for the airway assessment as well. So routinely, like most of the surgeons, they ask like what are the investigations routinely we are going to do in this particular case. For example, like patient is posted for circumcision, and it's only small surgery, small minor surgical procedure, and what preoperative investigations you need. Usually because of documentation purpose, we have to go for routine preoperative hemoglobin concentration is mandatory. At least like what we know by hemoglobin concentration is like oxygen carrying capacity. As I told you, less than 10 gram per deciliter, we have to thoroughly investigate the patient, like why the hemoglobin is low. If at all, if it is more than 10, or like if you go, the serum creatinine also is useful for renal excretion of the drugs. So at least serum complete blood count and serum creatinine is minimum investigation that is required. But if you go for like a premature infants or neonates or those patients who is having sickle cell disease, or like where you are expecting like blood loss is more, you are going for major surgeries, or where there is metabolic or endocrine or renal disease involvement is there. So we have to go for all routine investigations, including like liver function tests or renal function tests. So suppose a child is posted for upper respiratory tract, posted for surgery, but the child is having upper respiratory tract infection. Usually, the nasal because of this pediatric patients, they are obligate nasal breathers, and there might be nasal congestion. 50%, as I told you, most of them they will be having nasal congestion because of a seasonal variation. Most of them they will be having running nose. So in those cases, whether we have to postpone the surgery or we have to continue with the surgery, that is another question. So if you see the upper respiratory tract infection, usually there might be mild, moderate, and severe infection. If there is moderate to severe infection, for example, there is fever, purulent sputum, there is crackles, there is crepitations, rhonchi. If you go when you auscultate, so such case it is being considered as moderate to severe. We have to postpone the surgery. In case of mild, only there is a running nose, there is no fever. So then those cases we can manage with the help of giving antihistaminics, and then we can take up the surgery. So why whenever there is increased upper respiratory tract infection, there is chances of increased incidence of excess secretions. There might be airway obstruction, chances of laryngospasm and bronchoconstriction. So because of these worrisome complications, why we are postponing the surgery in case of moderate to severe infections. And in this particular cases, if at all you are planning for surgery, LMA, that is laryngeal supraglottic devices, is more beneficial as compared to the endotracheal tube, normal endotracheal tube, because the presence of endotracheal tube itself, it causes secretions, it causes irritation of the airway, and there is again chances of laryngospasm and bronchospasm. So moderate to severe, we have to postpone. As I told you, these are the signs and symptoms. Whenever this thing is there, we have to postpone the surgery at least for 2 weeks. Control with intravenous antibiotics or oral antibiotics, and then we can take up for the surgery. So consent, we have to discuss with the parents, like for each and everything we have to take consent. Like for example, you are planning for caudal block or epidural block or spinal anesthesia, wherein like we have to discuss the pros and cons, like what are the risks that is being involved. At the same time, we have to discuss the risk that is involved in the general anesthesia, especially lower abdominal surgeries. Usually the caudal block is being performed. So we have to take consent, we have to explain the parents that this is the thing, like what we are going to do, and we have to discuss with the video as well, if at all it is present. So coming to the preoperative fasting, as I told you, even fasting for 6 to 8 hours, it doesn't guarantee that there is no chance of aspiration pneumonia, because of the lower esophageal sphincter that is poorly developed. So this itself, it causes there is chance of aspiration pneumonia. So these are the various guidelines, like we have RCN guidelines, American Society of Anesthesia guidelines, we have European Society, we have Canadian guidelines. Whatever it may be the guidelines, what we follow is the clear liquids. The patient should be fasted for 2 hours, breast milk for 4 hours. The infant formula, what we have, if they are using, we have to fast for 6 hours. Light meal, you have to 6 hours. And if the patient is having like fried foods or fatty food, especially chicken or meat, so it has to be for 8 hours fasting. So coming to like what are the various anesthesia sites, like option available, will be using topical anesthesia, intravenous induction, inhalational induction, or regional anesthesia. So what type of anesthesia? Usually because of the getting intravenous cannulation is very difficult, and by the using of vein viewer, we can easily visualize by the light that is present, and we can secure the intravenous cannula. So before that intravenous cannula, it is very painful procedure. If at all the patient is cooperative, parents are cooperative, then we can apply this EMLA cream, which is a eutectic mixture of 5% lidocaine and 5% prilocaine. But the thing is, we have to at least 45 minutes contact with the body surface is necessary to have its action. So this lidocaine, it doesn't have any side effects, but this prilocaine has methemoglobinemia, especially in case of premature neonates. So we should be avoided in these particular cases. So what pre-medication is necessary? Usually preoperative sedation is not necessary in case of all neonates. It is not necessary. But yes, some of the patients, like very fussy patients, the parents are worried. So in these cases, ketamine is an excellent analgesic drug as well as induction drug also. We can use for as a oral preparation. It comes as oral preparation, intramuscular preparation, intravenous preparation, per rectal preparation. So we can use this ketamine as an pre-medication. So what monitors we have to attach? The routine monitoring, ASA monitoring, standard monitoring. What we have is ECG, blood pressure monitoring, non-invasive, SpO2 pulse oximeter, capnogram is necessary, and temperature probe. As I told you, if you are planning for prolonged surgeries, we have to note down the temperature. At the same time, we have to calculate the dose of atropine and succinylcholine, and it should be kept ready. It should be kept ready for the syringes, whatever it is. You have to keep labeled and you have to keep ready, because at any point of time the patient may undergo laryngospasm. So in those cases, succinylcholine is the drug of choice. So we have to keep this succinylcholine drug in hand, not like after having the complication. So we have to prepare these syringes like atropine and succinylcholine prior only. So inhalational induction, sevoflurane, if you know, this is the volatile agent of choice. We have isoflurane, we have halothane, but because of halothanes, irritation of the myocardium, which causes arrhythmias. Isoflurane also same thing. But when compared in the market, what we have is sevoflurane, which is the best volatile agent of choice because of its smooth induction, less irritant, and if you are suspecting difficult airway, also sevoflurane with 100% oxygen is literally safe. So it has a rapid action, rapid awakening also. If we have intravenous induction, we have propofol, ketamine, and thiopental. This propofol is we can use for all age groups. The dosage is 3 to 5 milligram per kg. Ketamine, it should be only reserved for cardiovascular disease when there is cardiovascular shock, or like there is like any valve abnormalities cases. Those cases we have to restrict the ketamine. Thiopental nowadays we are not using. Because it causes, as I told you, it causes more respiratory depression, so we are not using that one. And before performing any anesthesia, as I told you, the operation theatre should be priorly warmed because of the temperature, heat loss from the patient. So these things we should keep ready, like oropharyngeal airways, various sizes, oropharyngeal airways, nasopharyngeal airways. As I told you, the laryngoscope blades should be straight blade, also should be kept, and curved blades also should be kept, because as I told you, the airway, it may the chances of difficult intubation. So we have to keep all the sizes of endotracheal tubes, cuffed and uncuffed, stilate, bougie, and then we have this glide scope, and in our operation theatre we have this STOS microscope, which is very useful, very handy in case of difficult intubation. We have this fiber optic bronchoscope as well. So the special circuit what we are using is, this is called as Jackson's Reese circuit or Mapleson F circuit. This is the valve that is present. If you open the valve, there is we can have the spontaneous ventilation of the baby. If we at all you want to have controlled ventilation, just close the valve, then we can easily ventilate the patient. So for every patient, whatever it might be, because it might be adult or adult population or pediatric population, for everything we have to have, like, we have to think that it is a difficult intubation, and we have to have plan A, plan B, plan C, and plan D. Like, what if this anesthesia fails, or like what if like I'm unable to intubate? So for every pediatric patients, at least 2 anesthesiologists should be present for securing IV cannula or for intubation as well. Most of the patients it will be easy intubation, but we don't know like what time, what what will be happening. So we should have at least call for help. One anesthesiologist should be present if you are starting any pediatric cases. So plan A, if it fails, we have to go for plan B, and then finally cricothyrotomy set also should be kept ready because of difficult intubation. So as I told you, during intubation, this is the positioning of the patient. So coming to maintenance of anesthesia, usually maintenance by oxygen, nitrous, then inhalational agent, then plus or minus muscle relaxants we have to see. Usually the hand is being exposed because hand is exposed to the external environment where there is hypothermia. So if the hypothermia is present, then the pulse, maybe the sinuses as well as bradycardia, there might be chances. So we have to cover the hand, and then pulse oximeter should be kept handy. The BP cuff also we should be seen that, like the IV infusion, what the same hand we should not be used for BP cuff. We should use the contralateral hand. Tube should be securely fixed, and you have to the ventilation what you are going to achieve, it should be through capnography. It just not by mere auscultation or like by seeing the chest rise. We should not confirm the placement of the endotracheal tube. It is very misleading as well. So we have the most confirmation. This thing is by capnography. The tube placement. Even the intravenous fluids what we are using, it should be like, there should be a filter, so that like whenever there is air bubbles, especially in case ASD or BSD patients, there might be paradoxical air embolism, so that should be avoided. And then following surgery, after surgery is over, so we should warm the patient. Patient should be well saturated, normocarbic and pain free. As you know that like cold acidotic neonate will not breathe post-operatively. So we have like LMA or endotracheal tube. Endotracheal tube, it can be reversed after this thing. It should be whenever the patient is awake only we have to remove the endotracheal tube. But LMA, it can be removed either deep or awake depending upon the reversal of the patient. So if you see for the pain relief, as I told you, we can't assess like what type of the patient, whether it's for what the patient is crying. So we have this simple pain scale. This is where 0 is there is no pain, pain free, and 10 is the worst pain that the patient has been experiencing. Usually paracetamol and NSAIDs usually we use, but NSAIDs again it depends upon the renal function, and premature neonates NSAIDs should be avoided. Paracetamol is safer. Whenever possible, lower abdominal surgeries, plan for caudal analgesia or epidural blockade. This is the caudal block what we are going to perform. This is the we can push a catheter over here as same as in epidural anesthesia what we use. We can use a catheter, and post-operatively continuous pain relief can be done, especially for lower abdominal surgeries. So if you see post-operative complications, the most common complication, as I told you, the airway obstruction is because of large tongue falling back. Because of anesthesia, because of sedation, the tongue usually falls. So that thing we have to see at the posture of the airway. So other complications are nausea and vomiting, laryngospasm, hypoxia, inadequate ventilation and oxygen, as well as bronchospasm. The laryngospasm, usually this is the most dreaded complication. Laryngospasm, it is by definition it is called as like a sustained closure of vocal cords resulting in partial or complete loss of the patient's airway. It is uncontrolled and it is involuntary as well. There is muscular contraction of the vocal folds. It is more common in children than in adults. The risk factors that is being mainly involved is like you are using inhalational induction, or patient is having pre-existing asthma, URTA, upper respiratory tract infections, or chronic lung disease. The chances of becoming more cyanosis is more in children as compared to adults. And partial laryngospasm, if you see, we can be treated by 100% oxygen, CPAP, gentle assisted ventilation, and propofol 1 to 2 milligram per kg bolus. And if there is complete laryngospasm, you have to give 100% oxygen, CPAP, and suxamethanium. As I told you, like suxamethanium and atropine, these 2 syringes should be kept priorly loaded, and according to body weight, we have to administer to treat the laryngospasm. The another complication is post-operative nausea and vomiting. Usually it is uncommon under the age of 2 years, but in case of high-risk surgeries like adenotonsillectomy and squint surgeries, the incidence is more when compared to other surgeries. So we have to use antiemetics, 5-3 antagonists, especially ondansetron, dexamethasone 0.1 milligram per kg. It is more beneficial for post-operative nausea and vomiting. And these are my references. Thank you.
Thank you, Dr. Manjunath, for the wonderful presentation. The topic is now open for discussion. Any questions from the audience? And we have our anesthetist, Ajit sir. So, Ajit sir, can you please add few points to the discussion? Ajit sir already left. Sorry. Any questions from the audience? If no questions, then we can conclude the session. So the post-test and evaluation posted in the chat box as well as in AHS WhatsApp group. So please fill up the post-test and evaluation before concluding the session. And thank you once again, Dr. Manjunath, for the wonderful
Thank you.
presentation. So see
Definitely.
you all for the next Sunday CME. Thank you.